Hello, my name is Allison Carr, and I am a current pharmacy resident here at UTMC, and I will be presenting on drug-induced liver injury. The objectives of this presentation are to discuss the diagnosis and risk factors for drug-induced liver injury. We'll identify the three main types of drug-induced liver injury, hepatotoxicity, and the differences between them. I will review the presentation, mechanism, and treatment options of acetaminophen toxicity, and we will also utilize resources to aid in identification of drug-induced liver injury. So some background here on drug-induced liver injury. The incidence is estimated to be between 14 to 19 cases per 100,000 persons. Jaundice is accompanied in about 30% of those cases. Drug-induced liver injury, which I also might refer to as DILI later in the presentation, is responsible for 3 to 5% of hospital admissions for jaundice. Additionally, it's the most frequent cause of acute liver failure in most Western countries and accounts for more than half of all cases. So the diagnosis of drug-induced liver injury is a diagnosis largely based on exclusion of other causes. There are many elements that must go into this diagnosis. These important characteristics are, first, the timing of onset of injury after an agent has been started, which is called latency. Resolution of symptoms after an agent is stopped. We also refer to that as de-challenging. Recurrence upon re-exposure of an agent, which would be re-challenging the patient. General knowledge of the agent's potential for hepatotoxicity, or like the likelihood of DILI to occur. Clinical features, or the phenotype, are major diagnostic elements in drug-induced liver injury. One resource that you may want to consider using is LiverTox. This is a national database that comes from the National Institutes of Health on hepatotoxicity. This website appears as a PubMed page, and you are able to search for free amongst their database. So the LiverTox database has descriptions of more than 1,200 agents and their potential to cause liver injury. Now, the LiverTox website doesn't just include prescription medications that can cause drug-induced liver injury, but also OTC medications, herbal products, nutritional supplements, metals, and toxins. I will later in the presentation go through and show you what exactly the LiverTox database looks like. There are a lot of considerations to make when you're diagnosing someone with drug-induced liver injury. So one, drugs are not tested in patients with end-stage liver disease. So we want to use additional caution in those patients who are if we're using an agent that we suspect might have hepatotoxic effects, because that might be amplified in these patients knowing that they already have liver disease. Additionally, in cirrhosis, pharmacokinetics and pharmacodynamics might be altered. So that includes just how our body reacts when it comes to CYP450 enzymes or just the dynamics itself. So we also want to use caution in any patients with cirrhosis. There are also risk factors out there for drug-induced liver injury. First one being genetics. So you may have heard of rapid metabolizers or ultra-rapid metabolizers. Some patients might be slow metabolizers. This is all considering polymorphisms in our CYP450 enzymes, which are responsible for the first pass effect of most medications. Not every medication undergoes a first pass effect, but it is important to know if your patient does have a genetic mutation that you would want to assess whether an agent is appropriate for them to use or not. I know that we do not have a lot of genetic testing information available for our patients, but if it is something that is charted, you can always ask someone in pharmacy whether them being an ultra-rapid metabolizer or slow metabolizer would affect a medication. Another risk factor to consider for drug-induced liver injury is alcohol ingestion. Alcohol ingestion increases the CYP2E1 activity and decreases glutathione synthesis. I will talk about this in just a little bit when I get into acetaminophen toxicity. Another risk factor for drug-induced liver injury is severe malnutrition. In this instance, glutathione is depleted, which also affects metabolism of medications. Another thing to think about, as we often do in pharmacy, is the presence of other drugs. So drug interactions can definitely cause or increase the risk of drug-induced liver injury. So we do want to consider that whenever we are adding on multiple hepatotoxic agents or agents that interact with each other. A few more risk factors are here listed here. So, now I'll talk a little bit about the different types of drug-induced liver injury. There are three main types that we think about: direct, idiosyncratic, and indirect. Primarily, there's always been direct and idiosyncratic types of hepatotoxicity related to drug-induced liver injury. But indirect hepatotoxicity is emerging as a third type. This is caused by the action of the drug, so what it does, rather than it by its toxic or idiosyncratic properties, or what it is. And I'll say this again in a bit, but this has largely come about as we now have more monoclonal antibody therapies and other things that have come to the market. So this slide really explains the difference between the three types of drug-induced liver injury. The most common of these is the direct hepatotoxicity. So that one's in the first column there. It's often dose-related, predictable in how it acts. It is also reproducible in animal models. What's really important to note as far as differences between all of these is the time to onset of injury after having the offending agent started. So with direct hepatotoxicity, that's typically rapid. And by rapid, that would be days, whereas idiosyncratic hepatotoxicity is more variable in its onset, typically days to years. And this new indirect hepatotoxicity that's beginning to emerge is more of a delayed time to onset, which might take months. It's also important to note that all three of these types of drug-induced liver injury have different phenotypes. The most common out of all of these is acute hepatic necrosis, which is one phenotype of direct hepatotoxicity. And then the causes of all of these are again different. So direct hepatotoxicity, which is what I will talk about more in this presentation, is more intrinsic hepatotoxicity when an agent is given in high doses. And the idiosyncratic hepatotoxicity is more metabolic or an immunologic reaction. Indirect is more the indirect action of the agent on the liver or immune system in general. So these are the most commonly implicated agents for each type of drug-induced liver injury. Direct hepatotoxicity is mostly associated with high doses of acetaminophen, niacin, aspirin, cocaine, IV amiodarone, IV methotrexate, and cancer chemotherapy. Our idiosyncratic hepatotoxicity is mostly seen with many different antibiotics. So amoxicillin clavulanate, cephalosporins, isoniazid, nitrofurantoin, minocycline, fluoroquinolones, and macrolide antibiotics. And finally, as I kind of alluded to before, this emerging indirect hepatotoxicity is primarily related to any antineoplastic agents, glucocorticoids, and then, like I had said, monoclonal antibodies, either against tumor necrosis factor, CD20, or checkpoint proteins, and protein kinase inhibitors. So again, as I mentioned, the major phenotype of drug-induced liver injury is acute hepatic necrosis, which is the most common form that falls within that type of direct hepatotoxicity. Acute hepatic necrosis causes abrupt ALT elevations, but only mild ALK Phos and bilirubin elevations. Acute hepatic necrosis can be fatal, but if it is not, then these enzyme levels might fall almost as fast as they rose. So if you do see a large jump in ALT uh, very quickly after starting an agent, that should decline if you are actually able to remove the offending agent. And typically, these drugs can then be restarted at lower doses without a recurrence of injury. So I think Tylenol is a great example in that aspect. If you had a patient with Tylenol toxicity, you are not going to tell a patient that they can never have any Tylenol ever again. So they can take it. It's just mainly a dose-related effect, and patients should be able to take lower doses of acetaminophen at a later time after their body has recovered. So once again, some of our typical agents, these are very specific to the phenotype of acute hepatic necrosis, are acetaminophen, aspirin, niacin, and ecstasy. And once again, this is often due to overdose of one of these agents. So, how do we treat patients with drug-induced liver injury? Well, the answer is definitely more straightforward than you might think. So, we want to withdraw the offending agent. We really do not have any specific treatments outside of using N-acetylcysteine or NAC for acetaminophen toxicity, which is why I will be talking a little bit more about that specifically in a moment. And then you also want to report the case whenever you do have a patient with suspected drug-induced liver injury. And this just helps add to some of the information that we already have out there and improves our databases and just general information about medications. So the FDA MedWatch is where you would report any suspected cases of drug-induced liver injury. As far as outcomes for patients with drug-induced liver injury, most cases resolve completely. There are three major exceptions, those being acute liver failure, vanishing bile duct syndrome, chronic liver injury, and cirrhosis. So a question came up during the live presentation that primarily what is seen with our patients is acute liver failure. So if they are the exception, how is it that most of these cases resolve completely? Well, we do have to remember that most of our patients, we might not even notice that some of this liver injury is happening unless they were admitted to the hospital. So the patients who are actually severely sick are the ones that are coming in with the acute liver failure. I had shown some lists too of the idiosyncratic hepatotoxicity. You can see that most of those are caused by antibiotics, and that's not something we typically see in the hospital as patients coming in from liver injury due to antibiotics. So I know that it seems like the incidence of acute liver failure is very high, and it seems like the likelihood of these patients recovering is not great, but it is definitely still the minority of patients, and most patients with drug-induced liver injury will recover completely. So if the patient does not resolve completely, drug-induced liver injury can be very serious and result in death or the need for a transplant for the patients. Next, I'm going to talk a little bit about acetaminophen toxicity, and I first wanted to go through patient presentation. So there are three different stages that we think about with acetaminophen toxicity. Stage 1 being the first 12 to 24 hours after ingestion. Patients might present with nausea, vomiting, anorexia, diaphoresis, or they could be asymptomatic, but it is most likely these patients will have lots of nausea and vomiting and not be feeling well overall. Next is stage 2, so that would occur between 24 and 72 hours after ingestion of acetaminophen. This is where we actually see an asymptomatic rise in liver enzymes and bilirubin. 72 to 96 hours after ingestion is what we call stage 3. Patients at this time are symptomatic again. They might have that right upper quadrant tenderness, jaundice, hypoglycemia, and encephalopathy. And this would be, you would only get to this stage 3 if treatment had not been started. As far as the mechanism of acetaminophen toxicity, this is all related to excess of the N-acetyl p-benzoquinoneamine, or NAPQI, which is a toxic byproduct of acetaminophen. So, acetaminophen, too, what we have to think about is, again, I had talked about earlier, patients who drink alcohol, they have an increase in CYP2E1 enzymes that actually increases the production of NAPQI. So that's why we worry both with excess amounts of Tylenol and using Tylenol and alcohol at the same time. It was discussed during the live presentation that um, there was a question of should we limit the amount of acetaminophen used in our patients who are alcoholics. So the answer to that question is that when we have patients who are actively drinking, we absolutely should limit their acetaminophen intake to less than or equal to 2 grams in one day. And remember that a normal adult, non-alcoholic patient with normal liver function, they can take up to 4 grams of acetaminophen in a day. We also have to remember that the biggest risk of acetaminophen toxicity and alcohol together is when that's actually occurring at the same time, when a patient is actually drinking and taking acetaminophen at the same time. After a patient does not have alcohol in their system, it still might be suggested to use no more than 3 grams of acetaminophen in a day, but the risk to the patient is minimal as long as the alcohol is out of their system. But again, all of this toxicity is really related to this NAPQI byproduct that forms when acetaminophen is broken down. So, how do we know who to treat for acetaminophen toxicity? Well, there is a great nomogram out there called Rumack-Matthew nomogram, and that helps us draw a line of when we have Tylenol levels available, when do we treat our patients? So, what's really important about this nomogram is that we need to make sure we get levels no sooner than 4 hours after suspected ingestion of acetaminophen. And it won't be accurate if we get those levels any sooner. Most patients are not eligible to receive activated charcoal to help get acetaminophen out of their system. So I would not consider that for these patients. So if they happen to arrive, say 3 hours after ingestion, we will want to make sure we still wait until the 4th hour to get a level on our patients. So an acetaminophen level is just the plasma concentration of acetaminophen, and what a therapeutic level for someone who is just using acetaminophen for pain relief would be about 10 to 15 in the plasma. Our threshold for treating at the 4-hour mark is 150. So if you're able to get a 4-hour level and it comes back at 150 or higher, you need to treat this patient for acetaminophen toxicity. That's what the solid line follows. Now, that there is some wiggle room here because the dotted line is the Rumack-Matthew line, and above that line, it's more definite that the patient will have actual liver damage. But we still follow that solid treatment line just to be on the safe side for our patients. And if you are ever questioning whether to treat a patient or not for a high acetaminophen level, you should absolutely err on the safe side and treat them, especially if you're unsure of exactly what their ingestion time was and that sort of thing. So this nomogram is really what needs to be followed to figure out when to treat somebody, and it is important that we wait at least 4 hours. These marks on here follow 4, 8, 12, 16 hours, and that's just because it's going along with the half-life of 4 hours for acetaminophen. Okay, so our treatment for acetaminophen toxicity is N-acetylcysteine, also referred to as NAC, or the brand name Acetadote. There are a couple of different things we can do to treat our patients. There's a 20-hour IV protocol. So the traditional 3-bag regimen is what we use here at UTMC, which I will discuss in a couple of slides what our procedures are. But it is important to know that there is some literature for a new simplified two-bag regimen. And the study that I have down at the bottom of the slide is the first one to have looked at that in 2016. And outcomes were similar for these patients, but it was much easier for everyone to follow the protocol with the two-bag regimen. So that is another option, but we still need to follow our procedures, which uses the three-bag regimen. The other option is the 72-hour oral protocol. So this is much more labor intensive. There's a loading dose followed by 17 additional doses given every 4 hours. So as far as the UTMC procedure for N-acetylcysteine, this drug is restricted to acetaminophen overdose indications in patients who meet criteria. This is important to note because um, there are other uses for N-acetylcysteine. Sometimes N-acetylcysteine is used to stabilize hepatocytes in patients with acute liver failure that we suspect are going to need transplanted. But as far as our procedure goes, we cannot use N-acetylcysteine for any other indication. Our procedure also states that we must use oral therapy with N-acetylcysteine unless the patient is NPO or cannot tolerate oral. And I do want to say that N-acetylcysteine really, it smells nasty, it tastes gross for the patients, and it really is not very well tolerated. I will say, I'll show you our dilution policies in a couple of slides, but it's not very well tolerated, and I would imagine that most patients would have to go through the IV protocol because they cannot keep the N-acetylcysteine down. So here is that information for oral administration. Our loading dose, like I had said, is first. So that is 140 milligrams per kilogram. And then that's followed by your maintenance dose, which each one is 70 milligrams per kilogram, given every 4 hours for 17 doses. So we actually dilute this to a 5% solution given with, or diluted with orange juice, a soft drink, or water prior to administration. I spoke with the ED pharmacist earlier who said that apparently Sprite makes the N-acetylcysteine the most easily tolerated out of all of these options that we have for us. So if you are trying the oral protocol on a patient, you might want to tell your nurses to dilute with Sprite. If a patient vomits within 1 hour of their dose, that dose should be repeated. And the procedure is unclear for how many times to try oral before we say that the patient cannot tolerate and we need to use IV administration. So for IV administration, as we had said before, we use the three-bag regimen at UTMC. The loading dose in this is 150 milligrams per kilogram given over 15 minutes. And for pharmacy, we have different ways to dilute each of these doses. So this one is in 200 mLs of D5. That is followed by 50 milligrams per kilogram. That's an infusion over 4 hours. And that's in a 500 ml bag of D5. And then finally, you give 100 milligrams per kilogram given over 16 hours in a liter of D5. So again, this is a 20-hour process in total, whereas the oral administration takes a total of 72 hours to treat patients. Okay, so I had mentioned before that I was going to talk about some resources to help you assess if your patients have drug-induced liver injury. And that's what I'll be covering here in the next couple of slides. What I think is the most important one out there, and I have actually used this on a patient who had acute liver failure, is the Naranjo algorithm. So this is an adverse drug reaction probability scale. This scale is really useful and you're able to actually answer yes, no, or don't know to give the patient a total score. Now, on the LiverTalks website, it does kind of walk you through how to fill out this algorithm, which is very helpful because it can kind of direct you if you are deciding between yes, no, or don't know for your patients. And they do suggest that you use the do not know score as little as possible in order to actually make this come out accurate. So this algorithm really, it's very helpful and it goes through a lot of different things. So previous reports on the same reaction that you're seeing, did the adverse event appear after you gave the suspected drug? Did the adverse event improve when the drug was stopped or an antagonist was administered? Did the event reappear when the drug was readministered? And as you can see, all of these questions are really weighted. So re-challenging a patient is one of the best ways we know that that was the offending agent and something causing drug-induced liver injury. So that question is weighted more and given more points on the scale. It has other questions here like, are there alternative causes that could have caused a reaction? Did the reaction appear when a placebo was given? Was the drug detected in blood or other fluid concentrations known to be toxic? Was the reaction more severe when the dose was increased or less severe when the dose was decreased? Did the patient have a similar reaction to the same or similar drugs in previous exposure? And was the adverse event confirmed by any objective evidence? So you can use this scoring system either on the LiverTalks website or there are calculators out there. But again, I do like how the LiverTalks website walks you through how to use the algorithm. And then when you finally get your score, the total scores then guide you to an interpretation of those. So if your total score is greater than or equal to 9, it's definite that the drug is what caused this adverse reaction. A score of 5 to 8 says that it's probable that this is related to an adverse drug reaction. And then a score of 1 to 4 is possible. A score of less than or equal to 0 is doubtful. So I keep talking about the LiverTalks website, and that Naranjo algorithm is available on it. But this is kind of what the database looks like when you just do a quick Google search. It's free to everybody, and this is how it shows up, almost like a PubMed page. But there's the search bar there, and you just type in whatever you think might be causing an adverse reaction or drug-induced liver injury. You can also scroll through and just go through the entire page of records for drug-induced, any of these agents that might have hepatotoxicity. As you can see too, it's not just necessarily the drugs, but both acetaminophen and acetylcysteine are on the LiverTox database. So there's a lot of different information out there. I would highly recommend going to this site if you do think that a patient has drug-induced liver injury. And with that, that's all I have for my presentation on drug-induced liver injury. If you do have any questions after viewing this presentation, my email is listed on the slide, allison.carr2@utoledo.edu, and I would happily get back to you with any questions that you might have. Thank you.